Good morning, dear professors and doctors. Our case is a female patient, 6 years old, first subject of spontaneous miscarriage, leaves in the sleep. Her condition started at the age of 40 days with appearance of recurrent abscess and skin rash. The rash was a form of resemblance papules, annular macular rash, and skin blisters, as shown in these pictures. The rash was not associated with itching. It first appeared in the face, it becomes light over the body. It was associated with recurrent attacks of low-grade fever, up to 2 spikes per day, not responding to antibiotics. The patient at first was following up with dermatology clinic and skin biopsy was done at the age of 9 months, showing neutrophilic dermatosis, which is a part of syndrome called as sweet syndrome. Patient was on low course of both systemic and topical corticosteroids for over 1.5 years with no improvement. So the patient presented to our clinic at the age of 4 years old with the same complaint of skin rash, but the rash was macular in character. There were no papules, no blisters or abscesses, and involving all the body, with appearance of new manifestations like arthritis in knees and ankle joints, with recurrent attacks of fever and fever throat. There was no history suggestive of other system affection. Regarding family history, she has positive consanguinity to similar condition in the family, and she has only one sibling and is was totally free. Regarding developmental history, the patient has normal mental development, which was proved by IQ test, but she had delayed motor development during her first year of life, but patient catch abnormal development later on, which will be mentioned later. Prenatal history, the mother had no complication during pregnancy or during delivery, and the patient didn't even need NICU measurement. By examining the patient, her height and weight were below standard deviation according to the score curve. Examination of head and neck, we noticed that the patient has dysmorphic features including hyperthyroidism, sudden nose deformities, and lipodystrophy, with associated erythematous macular rash over the face as shown in this picture. There were no pallor, no cyanosis, no hair fall. Upper limb and lower limb examination showed skin rash with annular configuration over upper limb with the small joints of the hand deformities. Lower limb joint show arthritis with limitation of passive movement associated with joint deformities. Joint deformities here can be explained by the chronicity of the disease and the chronicity of arthritis. Abdomen and back examination showed the same skin rash over the trunk and the back. There were no organomegaly or lymphadenopathy. Chest and cardiac examination, nothing abnormal was detected except for the same skin rash over the chest. Neurological examination, as we mentioned before, the patient has average mentality with delayed motor development, with associated hypotonia power grade 4 in upper and lower limbs with normal reflexes. And this can be explained by the chronicity of the disease and the long course of systemic steroids the patient received during her first year of life, with associated, as we mentioned, deformities in both upper limbs and lower limb joints.
At this point, to sum up our case, we had a 6-year-old female patient with neonatal onset of skin abscesses and skin rash in the macular form, with recurrent attacks of fever, arthritis in the lower limb joints with deformities, associated with dysmorphic features and failure to thrive. So what might be our differential diagnosis? At the beginning of the disease, infections, especially congenital infections and malignancy, was suspected because of the presence of fever and skin rash and arthritis. But now there are 5 possibilities due to the very long duration of the disease. Primary immunodeficiency was suspected also because of the presence of fever and recurrent skin abscess. Metabolic disease as mucopolysaccharidosis due to the musculoskeletal involvement, dysmorphic features, and failure to thrive. But there is no other system affection, and the average mentality makes this diagnosis is unlikely. So finally, pediatric rheumatological disease as autoimmune or autoinflammatory disease should be considered due to the presence of recurrent attacks of fever, skin rash, arthritis. The presence of dysmorphic feature and failure to thrive suggests a genetic background of this disease. So autoinflammatory syndrome are more likely. So investigations were done to reach our diagnosis. A preliminary investigation, CBC showed microcytic hypochromic anemia, sepsis screen showed we did extensive testing for infectious disease as virology and torch, they were negative. Cultures from blood and urine samples were negative. Inflammatory markers PRAAS, CRP, ESR, ferritin, and serum amyloid A, testing for primary immune deficiency, and it was excluded by flow cytometry. Autoantibodies done, AA was negative, was positive with low titer, and the anemia was negative. The pelvic abdominal ultrasound normal study schedule survey where was normal except the accidental finding of coxa valga of both femoral head. Echocardiography showed pulmonary hypertension with high pressure, 65 millimeter mercury, and dilated right ventricle, mild impairment of systolic function of right ventricle. Actually, these findings support the diagnosis of autoinflammatory syndrome, as it was mentioned in the literature that interferon-mediated autoinflammatory disorders have an impact on endothelial function and vascular remodeling, so the development of pulmonary hypertension. As we mentioned before, the patient did sleep biopsy at the beginning of the disease when she was following with a dermatology clinic.
بس هي قالت انترفيرون.
Sleep biopsy done at age of 9 months and was diagnosed as Sweet syndrome and received long course for corticosteroid with no improvement. So another sleep biopsy was done at age of 2 years old. It was highly suggestive of leukemic deposits. She did bone marrow aspirin and bone marrow biopsy and malignancy was excluded.
So let's go back to our differential diagnosis. We already excluded infections, immunodeficiency, malignancy, metabolic diseases is not likely. So is it a pediatric hematological diseases as autoimmune or autoinflammatory diseases? Why we suspected autoinflammatory diseases? We have a patient with skin rash, recurrent attacks of fever, arthritis, anemia with high inflammatory markers. So we started oral steroid colchicine and treatment of pulmonary hypertension, but unfortunately she showed mild improvement. So what type of autoinflammatory diseases fits with our patient? We requested whole exome sequencing and the results confirmed our suspicion. It showed a genetic diagnosis of autosomal recessive proteasome associated autoinflammatory syndrome. PRAAS. PRAAS is characterized by early onset of annular erythematous skin rash, especially on the face and extremities, as shown in this picture. Also associated with recurrent attacks of fever, severe affection of the joints and the muscles with hepatosplenomegaly and microcytic anemia. So we started interleukin-1 receptor antagonist anakinra, 2 mg per kg, and many papers suggest this trial. Anakinra showed in these papers with high efficacy in the autoinflammatory diseases. And our patient showed dramatic response after starting the anakinra in the form of improvement of the skin rash, spikes of fever, arthritis, and also the pulmonary artery pressure. Thank you so much.
Good evening, dear Professor.